Thank you, and thanks for your offer of help. Are you speaking on this issue? Very good. Thank you all for your great comments. We'll be moving to our next panel on rate issues. And, you know, for those of you who did squeeze in a comment in the last panel on rate issues, please don't feel obliged to say it again. We hear you. And we agree that our agencies that serve do so much with so little. And we know that it's time to make some changes. We're going to have that conversation. I want to invite our panelists to come forward. Jim Knight and Brian Winfield, Christopher Kent, Eileen Rishi, Marty Omoto, and we'll hear again from Ms. Kesarwani from the LAO's office and Luana Welch from Finance. We're glad to have Jim Knight and Brian Winfield from the California Department of Developmental Services. Mr. Knight or Mr. Winfield, would you like to begin?
Thank you, Mr. Chair. John Doyle. Mr. Winfield is here to address questions, but just wanted to present a brief overview on what's in our budget for
Mr. Doyle.
Rate adjustments. As the agenda points out, there is $64 million increase in the budget related to the minimum wage increase from $9 to $10 per hour that will go into effect on January 1st, 2016. This increase would be available to any vendors who currently have staff who are making less than the $10 an hour minimum wage. The other adjustment that we have related to rates is a $25.3 million increase for Assembly Bill 1522, the Healthy Workplaces, Healthy Families Act of 2014. This legislation, effective July 1st, 2015, provides employees who work a specified period of time in California with paid sick leave. And those are the significant related to rates.
Thank you. Anything else from your department right now?
No, not at this time.
Okay.
Thank you.
Stick around. I'm sure we'll have some good questions for you. Also, Christopher Kent, Assistant Secretary, California Health and Human Services Agency. Mr. Kent.
Thank you, Mr. Chair. I'm here today to talk about our efforts that we've been engaged in our Developmental Incentives Task Force. This task force was an outgrowth of the DC task force, where we had a great collaborative discussion about sort of setting the policy directives for planning for the future of the DCs. Out of that group, we hope to have the same sort of collaborative discussion with ultimately some good policy decisions come out for the community side. Because of the large nature of the issues in the community side, we broke it into 4 general groups. We have the rates group, the regional center operations group, the medical and mental health services and supports group, and the housing and employment group. We've begun in earnest our efforts on the first 2 topics, and we're switching back and forth monthly between them to try and give everyone time to sort of process and do the good work. We've had 2 full task force meetings and 3 work group meetings so far, 2 on rates. And since that's sort of the focus of this panel, I'll get to the rate work. I provided to Ms. Hicks a document we used in our last meeting. So far in our meetings, we've had a first meeting that sort of was a baseline. We wanted to understand sort of the world as it is and what exists, and then sort of talk about the general issues. From that conversation, which I think was very productive, we've sort of put together what I call DS Task Force discussion items, which I think you've been provided. This document sort of captured some of the general ideas that we discussed in the first meeting in terms of guiding principles and then constraints on sort of what exists in the real world. And the goal of this document was to sort of foster, agreement and consistency on what would an ideal rate system look like, because the rate system we have is not ideal. I tend to refer to it as rate spaghetti. It's depending on when in time you got a rate and what kind of services you provide and how they're characterized, you could get different rates. It's not ideal, and it's not necessarily working towards the best incentives to get the services to the clients. So in this document, you can kind of see some of the themes that we discussed. In the morning of our meeting, we discussed sort of the principles and the constraints, and the group wanted to add to those constraints things like geographic disparities, workforce issues, and oversight requirements, and other laws and regulations that may affect the system. The more exciting conversation, I think, was in the afternoon, where we sort of investigated questions of inquiry, sort of what would an ideal system look like, how would it function, and those sorts of things. By the end of the day, there was several sort of areas of general agreement that the group came to, and that was sort of that rates should be centralized and set by DDS as much as possible. There should be a standard rate setting mechanism. The rate should tie as close as possible to CMS rules. Billing code should be streamlined. Rate flexibility should be built into the system at DDS. Policy should be looked at to make sure they incentivize the correct rate structure. And there needs to be standards of quality and quality measure outcomes. So these are just sort of very general structural ideas, but we hope to in the next few months build on those and get more specific policy recommendations. Thank you.
Thanks you, Mr. Kent. Ms. Ritchie from the Association of Regional Centers. Welcome.
Thank you. Thank you, Assembly Member Thurman, members of the committee. Appreciate the opportunity to speak today. Eileen Ritchie, I'm with the Association of Regional Center Agencies. ARCA represents the 21 nonprofit regional centers that provide intake, assessment, service coordination, resource development, and quality assurance, and purchase services for Californians with developmental disabilities. California operates the nation's largest developmental services system, funded by $2.6 billion in state funds and nearly $2 billion in financial participation from the federal government. During the recent recession, California's developmental services system endured over $1 billion in funding cuts. These cuts destabilized the developmental services system and has significantly compromised its ability to meet its obligations to individuals served, their families, and to the federal government. Service provider rates and regional center operations suffer from chronic underfunding that threatens service quality, federal funding, and most importantly, the health and safety of the people that we serve. In 2011, California invested $150 per resident of the state in its developmental services system. In contrast, the average state expended $204 per resident. This is 36% more than California's investment. California's financial commitment when considering individuals eligible for the Medicaid waiver, which is our major federal funding source in California, is the lowest of any state in the nation. The average investment nationally is more than double California's expenditure. ARCA consulted with Norm Davis, a national expert on rate setting in developmental services. Mr. Davis examined rates for residential facilities, day programs, and supported employment services here in California. His findings were that California's rates are some of the lowest in the nation. States such as New York and Minnesota fund residential facilities at rates 2.5 to 3 times higher than the California rate. Mr. Davis further documented that Oregon and New York have rates that are more than double California's daily rate for day and work activity services. New York, Washington, Arizona, and Oregon all have supported employment rates that are 83% higher than California's rate for the same service. These low rates are further affected by California's high real estate and labor costs, including the nation's highest workers' compensation premiums. A recent survey of regional centers reported that since 2011, 435 homes, 57 day and work programs, and 15 supported employment programs have closed. In a recent survey of those same regional centers, the leading factor that was the reason for those closures was, in fact, low rates. A survey conducted by the National Association of State Directors of Developmental Disability Services documented that 32 of 37 states surveyed had caseload ratios less than 1 to 59. California has some of the highest caseload ratios in the country. Only 2 states have higher caseload ratios than we have here in California. Service coordinators make up about 54% of the regional center workforce. Individual regional centers must compete with local counties for case management staff. The reality of what the core staffing formula budgets for salaries and benefits for service coordinations falls far below what state or county equivalent leaves regional center no choice but to pay more by hiring fewer service coordinators and other critical employees. By 2014, regional centers employed 661 fewer service coordinators statewide than they needed to meet the required caseload ratio. Today, no regional center is meeting all of the mandated caseload ratios. And in closing, it's critical to acknowledge that our service system is at a breaking point and needs a targeted infusion of funding now in order to prevent the collapse of the system. The Lanterman Coalition, which represents the major stakeholder groups in California, has proposed an initial 10% funding increase to stabilize the community service system in regional centers and to prevent further decline. 2, they recommend a funding reform for both service rates and for regional center operations. And 3, they recommend during the interim years, because it usually takes states multiple years to do rate reform, they recommend that there be a 5% annual increases until that reformed funding is put in place. We fully support this proposal. I think it's very important that we all remember that back in 1997, the Centers for Medicare and Medicaid, who at that time was called HCFA, reviewed California's developmental services system and identified significant deficiencies that cost the state $933 million in lost federal funds. In order to continue receiving federal funding for the system, California makes assurances to the federal government in their Medicaid waiver applications and other federal applications that caseload ratios are being met and that sufficient services are in place to support the number of individuals being served. The current shortfalls in these areas resulting from underfunding pose a significant risk to the ongoing receipt of these federal dollars. The risk is greater now than ever as the system relies on nearly $2 billion annually in federal funds. Thank you for the opportunity to provide testimony.
Thank you, Ms. Ritchie. Marty Emoto from California Disability Community Action Network.
Thank you. Thank you for this opportunity. My name is Marty Emoto. I am a family member and an advocate. My older sister, Elena, had developmental disabilities and physical disabilities and mental health needs. She passed away in 2003, the same year that then Governor Schwarzenegger was calling for the suspension of the Lanham Act, and we were planning and organizing massive protest rallies at the Capitol when that happened. My other sister, who was younger, 2 years later passed away because she couldn't afford health care insurance and died of heart ailment. And so my family, like so many families in this room and outside this room, understand the anguish and desperation that we all feel when a system is facing collapse and has been hard hit by ongoing and continued reductions. And that desperation is true of workers in community-based organizations who are trying very hard to do the right thing and do their jobs, to the workers in regional centers and all the other agencies in the community who are trying so desperately. If one thing we learned is that we're all in this together. But our system has been hard hit. And part of that experience for me is serving on several task forces, including the Developmental Services Task Force and the Developmental Centers Task Force. And one of the things that we looked at is this historical rate chart for community-based programs. That was part of our work group discussion, I think last week. And if we could like to pass this out, it was actually done by put together by the California Disability Services Association. It's a very good document that outlines the rate history over the years. But we are now in a permanent environment of limited resources and growing demand for those resources as our population gets older. And if we agree that there's also help needed in other areas of the budget, such as the restoration of the cost of living for SSI SSP, for the state portion of the SSI SSP grants for the lowest income Californians with disabilities, if we agree that there's also need for targeted funding help for people, for children in CalWORKs, in child welfare services, in child care, Medi-Cal, if we believe that there's a need for the restoration of 7% service cut in IHSS and also the need to fund overtime so people are not harmed, if we believe all that, then it means that any possible help and funding in the developmental services budget needs to also be targeted and specific. And so we urge the following. For the long-term issues, request on an ongoing basis updates from the Developmental Services Task Force on its progress toward trying to finding permanent alternatives and solutions to the larger issues regarding rates, reimbursements, caseloads, and regional center operations, to review that progress in oversight hearings throughout the year. And I believe progress is being made. On the immediate crisis issues that many advocates have talked about, including myself, I would ask that the subcommittee have the Developmental Services Task Force convene to identify specific targeted areas that require immediate attention in the 2015-2016 budget that I have referred to as triage issues, and report back to the subcommittee those targeted specific areas where limited or one-time funding or changes in state laws can provide relief to providers, regional centers, and to the people they serve. The Developmental Services Task Force is actually it's not the perfect, but it is the right entity to direct this to because it has all the right stakeholders, including members of the Brown administration. Some of these triage issues should include funding to help offset the impact of local minimum wage increases, including help to offset impact of minimum wage increases that require increases to exempt staff to comply with California laws. Some of these triage issue recommendations should or could include the possibility of obtaining Medicaid Community First Choice Option funds, which matches federal dollars at a higher rate, 56%, for supported living and other regional center funded home care type services. And that triage issues recommendations could also look at possible changes in certain existing state laws and regulations, including possibly elimination of the need for agency audit requirements and other changes in laws or policies that could provide some relief to regional centers, to providers across the state. The triage of targeted help and funding should also include, if overtime is implemented for in-home supportive services and other home care services, trailer bill language clarifying that regional center home care funded services would follow the federal 40-hour work week, and that those providers are not joint employers to IHSS, and also address other issues critical in impacting families with developmental disabilities under the waiver of personal care services. And lastly, any permanent increases in reimbursements need to be tied to compliance with the home and community-based services regulations, either to programs in compliance or programs moving forward with a plan of transition. And there should be funding for transition for those programs not in compliance at the same level and care and respect that we give to the developmental centers. Everyone deserves a chance to change. And in closing, many are broken by life, to quote Hemingway, but some are made stronger in their broken places. And my community has been broken. And my community, the community in this room, will become stronger if you help us. Thank you.
Thank you, Mr. Emoto. Sorry for the losses in your family that you've described, but thank you for your advocacy and what you've shared with us today. Thank you. Ms. Kesarwani, is there anything from the LAO's office?
Yes, thank you, Mr. Chair. Rashi Kesarwani with the Legislative Analyst's Office. I'll be providing a brief, high-level overview of the rate restrictions that were implemented over the last decade. Since 2003-04, several restrictions on rates paid to vendors were implemented as a means of achieving budgetary savings. These restrictions generally fall into three categories. First, there are the rate freezes. Next, there is the implementation of median rates. And finally, there were temporary rate reductions that have since been eliminated. Some vendor services experienced rate freezes beginning in 2003-04, and by 2008-09, all vendors with rates negotiated with regional centers experienced these permanent rate freezes. We note that there have been some exceptions to these widespread rate freezes, including a 3% increase in 2006-07, rate increases related to the minimum wage, such as the one proposed for 2015-16, as well as health and safety exemptions. Beginning in 2008-09, regional centers were required to negotiate a rate with new vendors that did not exceed the median rate for a particular service. Finally, temporary rate reductions were implemented beginning in 2009-10 through 2012-13 for total savings of about $250 million general fund over the 4-year period. These temporary reductions were fully eliminated beginning in 2013-14. And briefly, I want to note that on the two proposals that appear in your agenda related to the minimum wage increase and the paid sick days requirement, we recommend approval of the governor's proposed augmentations. Thank you.
Thank you. Ms. Kesarwani, I'd like to ask for a written copy of that rate analysis because with the exception of Ms. Grove, every single member of this subcommittee is new to this subcommittee. And I want the members of the committee to understand that history that you just described of chronic rate cuts and what I would say is not necessarily been matched in rate increase. So if you could provide that in writing for the members of the committee, I'd appreciate that.
Sure, Mr. Chair. We actually prepared a handout in the fall, and so I can refresh it and make it available to the committee.
Fantastic. Thank you. Anything from finance? Thank you. Any questions from the committee?
I just want you guys all to know that I support and would support a 10% rate increase for the community and restoration of the money that was taken from them in the past. I think your statements that you made were extremely right on, and I really appreciate what you're doing, and I hope that, I really hope that that can happen this year.
I'll ask a couple questions. I think I'll start with Mr. Doyle and Mr. Kent, if you would like to answer this. I cannot remember. Well, first of all, I don't know if he's still in the building. I think I chased him out with the 1-minute rule. Jim Shorter, who I used to work for. Sorry, Jim. The 60-second applies to everybody, even if you were my boss. But I have to give him this shout-out. Jim Shorter always points out to me, he's the executive director at Golden Gate Regional Center. He has for years pointed out to me the caseload ratio challenge and that we just don't have enough case managers. And Ms. Ritchie pointed it out in very eloquent detail. And I just want to get clarity about this caseload ratio issue and what steps are being done in the budget to rectify it. And the reason I ask that is because what I do remember is that the state of California is subject to audit from the federal government for not meeting the caseload ratio, and I'm sure that there's some consequences for that. So I want to know what are the steps being taken in this budget to rectify that caseload imbalance.
Regarding what's in the budget related to adjustments for increasing case manager positions, the only adjustment that typically goes into the budget is when there are, as caseload increases, there's one-time funding put in. But it's not sufficient to increase levels to a point where they would be in compliance with federal ratios. The way that we see this moving forward is through the task force. As Mr. Kent mentioned, there is a work group related to regional center operations, and in that work group we think we have the ability to look at the issues that are facing all 21 regional centers, how they're impacted and how we move this forward.
Let me ask my question a different way then. If we are out of compliance, and we are, with federal guidelines, what's the consequence for being out of compliance on caseload ratio?
There is a possibility that we could lose federal funding. We haven't been notified by the federal government that our being out of compliance is an issue at this point.
But
So
we know
there is a possibility.
we know that we are out of compliance, though,
Yes, we
right?
do.
By caseload ratio. I'm not that good at the math, but even I know the math that if you have to have so many case managers
That's
and
correct.
you don't, we're out of compliance.
That's correct.
So if we're out of compliance and the only source of funding for regional centers is the Department of Developmental Services through the budget, then we're at risk, we're exposed. So that's why I'm asking the question, what are our steps within the budget to rectify
And there is
that
nothing.
situation?
There is nothing in the proposed governor's budget to rectify that situation.
So let's be on record that we find that unacceptable, that we have to have action to close the gap, because as you've stated, we stand to lose potentially how much from the federal government if we're found out of compliance, which we already know we are.
We receive approximately $2 billion in federal funding.
It's not a small chunk of change, $2 billion. So let's please let the record show that this committee is expecting action on the budget to close the gap on caseload ratio sizes so that we don't lose that money and so that we can provide the services for those served by the regional centers. Thank you. My second question.
I applaud the chair. I applaud the chair for that. Thank you. Thank you very much.
I'm just doing simple math. I can't do those big figures in my head like you do and how much the community gets, Ms. Grove, but I do get that if you're supposed to have so many staff to serve so many people, you just have to have it. And if it's a federal requirement and we are in compliance, and that is a fact, then we have to. And if we only have one source to our budget, then the only way to close the gap is through the budget. And so I'm just saying I don't want California to be irresponsible. That's all I'm saying. That's all I'm saying. And I know that those we serve will benefit from that. My second question, this I honestly cannot remember. If you qualify to be served at a regional center, is that an entitlement? Is that considered an entitlement? In the same way that we have other, I spent the last 4 years working for a mental health agency that used Medi-Cal. It was impressed upon me that if you were eligible for Medi-Cal and we did not provide the service to you, we were in violation because it's an entitlement that must be provided. So my question is, if you're eligible to be served by a regional center, and is that an entitlement? And even if it's not, I guess my question is this. If we have, as a state, allowed for these rate cuts for so long at 10%, and I know for a fact that vendor agencies have closed as a result of these rate cuts, aren't we in effect denying those who are eligible for these services of their entitlement, or at least what should be their entitlement, if by law it is not currently an entitlement? Mr. Doyle or Mr. Kent, if either of you would like to take that. And I know Ms. Ritchie would like to. She can be next.
As you point out, Mr. Chair, the program is an entitlement program. And it is true that some vendors have, because of rates that are paid, have stopped providing services. Other vendors have come in and picked up some of those services, sometimes not. There are issues where, we've heard concerns about wait lists and things. But at this point, the program is still an entitlement program.
How do you have any data that demonstrates reduction in services in general to those served in the developmental disability community as a result of the number of programs that have closed because of rate issues?
We've been asked that question in the past, and it is difficult to, given the number of providers that we have thousands of providers, it's difficult to put a finger on who closed because rates were too low, who closed for other reasons. It's something we've looked at, but I don't know that we have very definitive data.
We're going to work with you because we're a friend to the department, but I'm certain that someone who's waiting in this line to speak is going to say that they have the data and they're happy to offer it. but we're willing to work with you because I want to see analyses of what we think are even conservative estimates of reduction of service or loss of service. What is the impact of that historical rate reduction that we just heard about, so that we can really give thought to where we should be rate-wise, just based on facts, based on projected loss of service as a result of a sector that has been impacted by a history of rate cuts. So if you would pass on to your team that this is an expectation from this committee, that we're going to have a conversation about what the impact of lost services has been on the community as a whole as a result of the rate issue.
Absolutely.
Thank you very much. Mr. Kent, did you have anything to add?
Thank you, Mr. Chair. I'd just like to add that, in terms of the regional center core staffing, that is a major focus of the group. We've talked about it, and we will be looking more into that issue. So.
Is the task force have some timeline to make its recommendation, and specifically a recommendation around the caseload ratio issue?
We've not determined that yet, but we are working towards it, and with your sort of direction, we'll keep working towards it.
Anyone who knows me will tell you I'm always in a hurry, and everything's always urgent. So if you would share to the task force members on our behalf, let's hurry, it's urgent.
I will do, and
Thank
they echo those sentiments as well.
Thank you very much, sir. Ms. Ritchie, did you have anything to add?
Well, I just want to say if the association can be of any assistance in gathering this information, we certainly stand ready.
Move as you will. I'm sure that you can help, and so you don't need permission as you have that information. This committee is interested in having it, but please make sure you share it with the department, the governor's staff, and finance, because we want this to be an ongoing conversation.
Of course I will. Thank you.
Thank you. Assemblymember Grove has a question.
Thank you. I do. I truly do applaud the chair. I've sat on this committee for 4 years, and I have never had a chair take such a bold statement as to defend the community. So I really, really do applaud you from the bottom of my heart to defend these people. I do, just for historical knowledge, would you guys please tell us how long that we have been out of compliance for case ratio, just for kicks?
I don't have that detail readily available, but we can look at it.
And bless your heart, I know you've only been here for a year. Has anybody got a wild guess? Anybody else on the panel? You going to get me that, Miss Ritchie?